Greetings. My name is Dr. Sanjeev Chopra. I'm a professor of medicine at Harvard Medical School, and I'm privileged to head the advisory board of Know Your Meds. Today we are launching Know Your Health, and I'm delighted to welcome as our first guest, Dr. Frank Domino, who's a professor of family medicine at the University of Massachusetts School of Medicine. He's a brilliant clinician, scholar, and teacher. He's won a number of prestigious teaching awards and speaks nationally and internationally. Today we're going to discuss the topic of screening for colon cancer, and particularly the role of colonoscopy. Colorectal cancer is the third most common cancer in men and women in the United States. Now let's be very clear about the word screening. Screening means one does a test. It could be a blood test, it could be a CAT scan, it could be an endoscopic procedure, but you do it in persons at high risk for developing that disease, but they have no symptoms. So for colorectal cancer, if they already have blood in the stool, or they have symptoms of change in bowel habits or weight loss, and then one does a procedure, that's not screening, that's a diagnostic test. So Dr. Domino, how well are we doing in the United States with screening for colorectal cancer?
Well, first, Dr. Chopra, thank you. I'm honored to be here and to participate in this inaugural event for Know Your Health. Colon cancer affects many adults, and back in 2010, the data on how effectively we were screening for colon cancer was not very good. About 1 in 3 adults were being appropriately screened. By 2018, that had gotten somewhat better, showing about 65% of adults were being screened. That unfortunately means now 1 in 3 are still not being screened. So there's plenty of room for improvement. And we know that screening for colon cancer decreases the rate of illness and death from having colon cancer.
Terrific, thank you so much. So I think we need to create awareness, and that different medical societies, including the one you belong to, the one I belong to, the American Gastroenterology Association, have to take a part in informing the public that this is a very safe, effective procedure. Here I'm talking about colonoscopy. The risk is very negligible. The preparations have improved. And individuals over the age of 50 should get screening colonoscopy. There are certain patients who may need screening colonoscopy at a younger age. Can you comment on that?
Well, yes. So the current guidelines say that all adults 50 to 75 should be screened for colon cancer. And there's very, very good evidence to support that recommendation. And recently they've expanded that recommendation that says if you're 75 to 85, you should also be screened if you're in pretty good health, with the assumption being that you're going to live another 10 years. So right now, the current guidelines have extended from age 50 to 85 for those who are relatively healthy. Things that might get you screened earlier are having certain conditions. Diseases like Crohn's disease and inflammatory bowel disease. If you have those conditions, you should be screened earlier for colon cancer. If you have a family member, say a parent, who developed colon cancer at an age before or right around 50, you too should be screened earlier based upon when is a discussion with you and your doctor. Finally, there's rare genetic conditions that increase the risk of colon cancer. You may have heard of Lynch syndrome and other things like that. Those things are fairly uncommon, but if you have a family history or a personal history of those conditions, you too need to be screened before 50.
So let me summarize that again. So under the age of 50, individuals who have inflammatory bowel disease, there are two kinds, Crohn's disease and ulcerative colitis. Ulcerative colitis only involves the large bowel or the colon. Crohn's can involve the small bowel, the large bowel, or both. If it involves the large bowel, the colon, or both, then those patients are at risk for developing colon cancer. And then you mentioned rare syndromes like the Lynch syndrome, in which these individuals are susceptible to more than one cancer type, including colon cancer. So wonderful. So I'd like to show at this stage a video clip of a famous sort of celebrity, a news anchor by the name of Katie Couric, who underwent colonoscopy, and the procedure was shown on national television. She had lost a pretty young husband to colorectal cancer. And I really admire her for having done this a few years ago.
So this is the medication we're giving you here.
What is that?
This is Demerol. So you're going to get a little groggy from this maybe, but it's a nice, relaxing feeling. Okay.
I'm a little nervous.
Sure, that's
Is that normal?
normal. How do you feel?
I feel very lethargic. I feel the way I feel right before I go to sleep.
Right.
Okay.
Good. We know that the medicine is taking effect because you're having a little trouble getting out some of your words, so we know that you're all
Right.
sedated. Yeah.
I have a pretty little colon.
Actually, this is good for thinking of production because here she is not overly sedated, you see, and is able to appreciate what is going on.
But you
and
didn't
yet
put the
is not
scope
over-
in yet, did you?
Yeah, we're doing the examination.
Oh, really?
Yeah, we're doing
Okay,
it.
good.
We're-
That's a good sign.
We're doing it. We're almost done. You're going to feel a cramp there now,
Yeah, I did.
going around the band.
You can take some nice deep breaths if you feel the crampiness. Try slow deep breaths, nice and easy.
I have a lot of blood vessels. That's normal,
Those are
huh?
normal, healthy-looking blood vessels.
What's at the bottom there that we're seeing?
At
Or
the
in
bottom,
center. In the center.
it's normal. It's just like when you're driving through a tunnel and your headlights haven't reached a spot. It
Oh, I
looks
gotcha.
dark, but once your headlights get up to it, you realize that it's clear. I'm going to have her roll flat on her back.
Really?
Yeah. Face the ceiling, but keep your right knee
Right
bent.
knee bent. Come flat.
Come on.
That's where the small intestine is, and I'm going to clear this fluid up so you see where, if you can see where the appendix takes off. In other words, we're 6 feet up. We're 6 feet up here. So
Jeez.
up,
That's
6 feet.
reassuring, Dr. Ford. Thank you for sharing that point with me. And our colons are always, aren't they generally 6 feet long,
Yeah,
colons?
yes.
So at the end of your
Even in small people.
You're at the end, we've reached the end of the colon.
End of the line. So we're going to come out now.
That's it?
We're up to the top, yeah.
Really?
Yeah.
I'll stay up there a little longer. I'm kidding. I'm kidding. I'm kidding.
Now we're coming back, and actually this is when we do a definitive look.
So you do more on the return trip.
Yes, yes.
So far I'm looking
So
pretty
far,
clean,
you're
huh?
very clean. So we're coming down nicely, and it's as clean as a whistle. This is a perfectly normal examination up to this point, and we're practically in the rectum now. Okay, Katie, that's it.
That wasn't bad at all.
No, no. And I
The only
I
discomfort I
purposefully kept you, sedated enough so you weren't terrified, but you didn't need any more so you could interact, and because you can understand how some people don't even take medication for it.
You know, the only discomfort was really sort of when you blew air in me, I guess.
You felt a little
A little
cramping.
crampy, yeah.
Right.
But other than that,
no.
I didn't feel a thing.
Okay, good.
You're brilliant,
You're a
Dr.
superb
Ford.
patient.
Thank you very
What a
much.
team.
Thank you so much.
Okay,
Thank you, guys.
good. And it was normal, which is the most important thing.
So no polyps, no
No
nothing.
polyps, no cancer, no inflammation, nothing.
Very good. So Dr. Chopra, as a family physician working in the community, many of my patients are interested in being screened for colon cancer, but they're very apprehensive about having a colonoscopy. They've heard from their family and friends stories that have concerned them. Can you talk a little bit about why a colonoscopy is so important and how to address these apprehensions?
So let's first talk about addressing the apprehensions, because if we don't address it, they won't undergo the colonoscopy. And we don't force our patients, we recommend. I often will say to somebody who's hesitating, if you were my relative, if you were my brother, if you were my uncle, if you were my aunt, I would insist that you have this procedure. It's a very safe and effective procedure. Fiber optic endoscopy is 50 years old, and the equipments have improved. We can do video screening. So what we do is we clean the colon using a prep. The preparations have become much easier to do. You start the preparation the night before, and yes, you do have to go to the bathroom a few times, and then just prior to your colonoscopy, but it is very important for the gastroenterologist doing the procedure to be able to look at the entire 4 feet of colon and get a very good look. We do have a suction device, so if there's liquid stool, it can be removed through the colonoscope. So it's a very safe procedure. It's not unusual to finish the procedure looking and examining the entire 4 feet of colon and then looking more carefully as one comes out in 20 minutes. If one finds a polyp is often shaped like a mushroom or a lollipop. So it has a stalk and then the head of the polyp. If one finds a polyp, one can snare it at the base and cut it. And as we are cutting it, we also cauterize it. So there's minimal bleeding. Again, a very safe procedure. Removing adenomatous polyps. There are two kinds of polyps in the colon, hyperplastic and adenomatous. Hyperplastic are benign. Adenomatous can either have malignancy in the polyp or it is pre-malignant. In other words, if we don't remove it, with the passage of time, probably in a few years, it can turn into cancer. Sometimes there's cancer in the tip of the polyp, so right on the head, but it has not invaded the stalk. And now if we remove it with an outpatient procedure, we have cured a patient who has colon cancer with an outpatient procedure. I think it was very brave of Katie Couric to undergo the procedure and broadcast it on national TV. And I hope that gives people a sense as to how it is done. There's a team, they monitor your heart rate, your oxygen saturation. Patients are given intravenous medication that causes both sedation and some amnesia. As you saw at one point during the colonoscopy, she says, you haven't started the procedure yet, right? You haven't inserted the colonoscope. And that's because she's sedated and has some amnesia, but it also tells us how comfortable it is. And good gastroenterologists will not force or insert the colonoscope if there are very strange turns or if there's a stricture and narrowing. Patients had a previous bout of very severe diverticulitis. So we have a rule. And one of the prominent rules is know your patient well, know your equipment well. And then a very important rule, know when to quit.
Well, so you've just told us that having a colonoscopy can look for cancer, and if it finds a polyp, it can take it out. And if there's a chance that that polyp is actually a cancer, you can cure that cancer just by having this procedure that's safe. But can you tell us a little bit about how effective it is when we screen an entire population with a colonoscopy? How effective is it at preventing death from colon cancer?
So we've always felt that it would lower the risk of colorectal cancer mortality. Over the age of 50 years, roughly 35% of the general population will have polyps. So 1 in 3 people will have polyps. If you do other tests like virtual colonoscopy, which is a CAT scan, or Cologuard, or you do testing of the stool for hidden occult blood, you may or may not identify colon cancer at an early stage. It may be already late. There are also what are called false positives and false negatives with these procedures. In other words, the Cologuard test, testing for abnormal DNA, may be positive, and the person does not have colon cancer. It also, if one does a test like this and it's abnormal, it now begets a colonoscopy, because these tests are diagnostic, whereas colonoscopy can be both diagnostic and therapeutic. It's also, you can offer a treatment. So it's a major advance. There's a recent publication in the premier gastroenterology journal, Gastroenterology, from Poland, and one colonoscopy done in the age that we talked about, over the age of 50. 17 years later, those people who underwent colonoscopy have lower mortality from colorectal cancer compared to those who did not have colonoscopy. So a very safe and effective procedure. I think what's going to be coming in the not too distant future will be the use of augmented intelligence, artificial intelligence. And we have trials going on right now, including at the Beth Israel Deaconess Medical Center. So at the time of colonoscopy, AI is incorporated, and you look at the polyp, and AI will say, this is hyperplastic. Don't even bother to biopsy or remove it. That will save fee, will save time. This is adenomatous. This may have cancer in it. You must remove it. So that is already happening in the field of endoscopy and colonoscopy.
Okay, so just to summarize a bit, you have told us that colonoscopy is both diagnostic, it can find pre-cancer and cancer, and it can be therapeutic, it can cure it. And there are other tests we can do, as you mentioned, a stool test and a CAT scan, and they both miss precancerous findings and provide no benefit. So if they see something, you still have to get a colonoscopy. Any final thoughts on what I can say to encourage my patients to get this life-saving procedure?
I think you can share with them that you and your colleagues over the age of 50, pretty much everyone has had a screening colonoscopy. It's very safe and effective, that you'll be in good hands. The person performing the procedure is very skilled, that the equipments have improved, the preps have improved. It's also good, Dr. Domino, to draw a diagram. Draw a diagram of the colon. You know, the sigmoid S-shaped, and then it goes up, and then across, and then down to where the appendix is, where the small bowel joins it, and say, this is how it's done. This is the scope that's inserted. And it's really during the withdrawal time that the gastroenterologist looks in every fold, every nook and cranny to make sure they're not missing a polyp. And if they find a polyp, they put a snare, they snip it off, they cauterize it. It is a very safe procedure. When we go to the recovery room to talk to the family and the patient, because they're still sedated, and we say your procedure came out great, and we give them the diagrams, we take pictures at the time of the colonoscopy if we find a polyp. And it's not unusual for the patient to say, when are you going to start? And you say, no, it's over. And that's why it's important to draw diagrams and give people things that they can take home and reflect on.
Well, thank you again, Dr. Chopra. It was my pleasure to be part of this inaugural Know Your Health video discussion on colon cancer and colon cancer screening. And I look forward to doing more in the future.
Thank you so much, Dr. Domino, for your time, your expertise, and your compassion and kindness to the patients. I know how much a beloved doctor you are. Thanks a lot.